Welcome to Somerset Medical Center's Health Talk. I'm Dr. John Bucek, Director of Somerset Medical Center's Family Medicine Residency Program. Nearly all of us at some point suffer from some type of gastrointestinal or digestive health issue, from indigestion to acid reflux, or more serious conditions like gallstone trouble, irritable bowel syndrome, and then, most concerning, maybe colon cancer. On today's show, we'll look at some of the common gastrointestinal issues and what's new in testing and treatment. Joining us today are Dr. Surya Irakam, a gastroenterologist at Somerset Medical Center, and Dr. William Sugerman, a surgeon at Somerset Medical Center and a member of the Colon and Rectal Cancer Institute at Steeplechase Cancer Center. Gentlemen, welcome. Thank you for coming today.
Thank you, John. Thank you for having us.
Let's, maybe a good starting point would be just to describe the gastrointestinal tract and give people an overview of, what are the parts, what do they do? Anybody want to start us off?
Sure. Yeah, I'll start. As a gastroenterologist, we basically take care of patients who have digestive system related symptoms. And digestive system really starts from mouth to the anal orifice. But we, even though it starts in the mouth, dentists and oral surgeons that take care of the, mouth-related issues, our area really starts from the food pipe, which medically we call esophagus, and stomach, small intestine, and large intestine. It happens that more common problems we take care of are related to esophagus, like acid reflux disease, ulcers in the stomach, and beginning of the small intestine. And a lot of times related to colon, as you mentioned, colorectal, colon polyps or colon cancer. And also very common condition called irritable bowel syndrome, which is common but not so, in terms of seriousness, it may not be as serious as the colon cancer. Gastroenterologists, we also take care of patients with liver disease and pancreatic diseases. Even though we're typically called gastroenterologists, our training and our expertise includes liver disease as well. I would also request Dr. Sugerman to add some more to the same topic.
So the gastroenterology point of view, how about a general surgeon point of view?
From the general surgeon point of view, I mean, we also focus on the gastrointestinal tract, as well as the liver, and especially the gallbladder. Be it tumors in the stomach or problems with the small bowel or intestine. Often the gastroenterologists are the ones who diagnose the problem, and then we follow up with either surgery or some other type of treatment. And
both of you look at the same imaging. Both of you sometimes share taking care of the same patients.
Absolutely, yeah. We, like Dr. Sugerman mentioned already, John, it seems like gastroenterologists most of the time start seeing the patients. They usually go to the primary care doctor with upper or abdominal symptoms like abdominal pain, heartburn, diarrhea, constipation, whatnot. And primary care doctors usually, unless there is a specific surgical problem immediately, otherwise they usually send to a gastroenterologist. And that's, we begin the testing, examine the patient, listen to the patient, and start the testing process. And usually they include blood tests, CT scans, ultrasonography, and a lot of times as a gastroenterologist, we also do endoscopy, colonoscopy, which we'll be describing a little more during the show. And once we have a specific surgical problem, that'll be the time we may be sending the patients to surgeons like Dr. Sugerman.
Let's pick one of the common things you mentioned. Let's say reflux or heartburn, GERD, gastrointestinal reflux. These are some of the common ways that it's referred to. Describe to me a little bit about what that condition is and how you might try to help a patient who had it.
Right. As you know, John, gastroesophageal acid reflux disease is a very common condition, as you mentioned. all age groups of patients, they do suffer from this particular condition. All of us, we produce acid in the stomach. And when we call this as acid reflux disease, what is really happening is the acid is backing up into the esophagus where that doesn't belong. And the acid being in the esophagus, that causes the symptoms, which seems to most common of them is heartburn. A lot of times, this can be taken care by simple measures like changing the lifestyle, being fit, eating less of fatty food, dietary measures. And also sometimes people start taking over-the-counter available anti-acid therapy, like simple things like bismuth, calcium, Maalox, Tums, Mylanta, that kind of medications. And usually by the time patients come to a gastroenterologist, they are typically labeled as acid reflux disease. When we call that particular name is when patients start having these symptoms more than a couple times a week. All of us can have heartburn once in a while, once in a few months. That's not uncommon, diet related. But when patients start having more than twice a week, typically we kind of label that condition as gastroesophageal acid reflux disease. The reason to diagnose that condition positively and try to take care of it is important because even though commonly it is not such a serious condition, potentially this can lead to very serious complications such as esophageal cancer. That is why it is important to diagnose and try to take care either with diet, lifestyle modifications, adjusting some medications. As you said, most of the people a lot of people can be managed with these simple measures. Some of them, they may need more stronger medications which control the acid level, like what we call H2 blockers, such as ranitidine, which is available as Zantac, or famotidine, which is available as Pepcid in the market. Even those are over-the-counter medications. Sometimes we use even stronger medications, a group of medications called proton pump inhibitors, like omeprazole. They're very effective. Sometimes in younger people, when they come into my office, we use these particular medications as a test itself to prove or disprove that somebody has acid reflux disease. But what happens is, as a gastroenterologist, my job is to recognize who has more serious kind of acid reflux. In other words, when patients are older than 55, we take it somewhat seriously. When somebody complains that they have difficulty swallowing, or when somebody notices that they're losing weight, or the primary doctor calls me and says, oh, by the way, patient is noted to have a drop in the blood count, commonly what we call anemia, then those patients, a lot of times we choose to do endoscopy. The reason for that is if I see a lot of ulcers because of the acid reflux disease, then that group of patients may need long-term medications for these particular problems. And also there is a condition called Barrett's esophagus, and this is caused by people having acid reflux disease for a long time, and that potentially could be a precancerous condition. We used to think that Barrett's esophagus was very serious, I would say a decade ago. But lately, we feel that it is not as serious as we used to think. Nevertheless, it is a precancerous condition, and we follow it closely.
So to summarize, if somebody's trying to take care of their reflux by themselves at home, and they're not really successful, or it keeps coming back, they should go talk to their doctor about if next steps are needed.
Absolutely, I agree with that. It is okay if it is once in a while, one episode of heartburn in few months, that's a different category. But once, as you said, they took for a period of time Tums, Mylanta, Maalox, kind of these medications, and they still keep having this heartburn again and again, I think it is better for them to at least to the primary doctor and take care of it carefully. And then usually to come to a gastroenterologist.
So that's a nice overview of a very common gastroenterology problem with patients. You mentioned, Dr. Sugerman, gallstone gallbladder disease. Can you give us like a similar overview of how this affects patients and how you help patients who are seen for these kind of problems?
Sure. I mean, gallbladder disease is extremely common. And what that basically refers to is people form stones within their gallbladder. And it's not really clear whether that's from diet or from weight gain, weight loss, but it tends to happen in people who are in their 40s, people who are frequently on diets or their weight is going up or down. It's more common in women. And what the classical symptoms are is that people will eat food, especially fatty food, and they'll get some pain either right in the center or in the right upper quadrant. And that pain can kind of radiate to their shoulder or their back. Usually it's self-limiting. It can last anywhere from minutes to hours. That usually brings it to the patient's attention, and they usually do see their primary doctor. Most of the time they'll get referred to see for an ultrasound, which uses sound waves to look at the gallbladder itself to see whether there are stones present or not. If there are stones present and they have the classical symptoms, they usually get referred to a surgeon, such as myself, to take the gallbladder out.
Take it out. Why not just leave the stones there?
If someone is found to have gallstones that are symptomatic, meaning they're causing symptoms, then the recommendation, unless there's a real reason not to take the gallbladder out, is to proceed. And the reason for that is that once stones become symptomatic, meaning once they start bothering the patient, they frequently go on to having more and more attacks. And the attacks, although usually are self-limited, sometimes they can progress to what's called acute cholecystitis, meaning that the pain persists and they need to have emergency surgery, or the stones themselves can leave the gallbladder and enter what's called the common bile duct. That's the main duct that connects the liver to the intestine. And when they pass through the common bile duct, they can inflame the pancreas, and they can get something called gallstone pancreatitis, which can be life-threatening. So in general, if patients have symptomatic gallstones, we do recommend taking the gallbladder out.
So you take it out when things are calm and the patient is healthy rather than wait for an emergency?
Correct. It is definitely safer to take the gallbladder out when people are feeling good as opposed to when they're not feeling good, because when they're feeling good, there's less inflammation, and it makes it much higher chance that I can do the surgery laparoscopically, meaning with the little incisions. When the surgery is done electively, when the patient isn't having severe symptoms, the chances of doing it laparoscopically are at least 98 or 99% of the time. So basically almost always. If it's in the middle of a very bad attack, that number drops. So it's definitely safer and easier for the patient to get it done when they're feeling good. It's usually done as an outpatient procedure, meaning they come in the morning and they go home the same day.
Oh, that sounds like less dramatic than it used to be, or less trouble for the patient to recover from than it used to be.
Certainly, with the old way, when you do it with the open incision, they're usually in the hospital at least 3, 4, 5 days. They miss several weeks of work. It's very uncomfortable. Nowadays, like I said, they come in the morning, they go home the same day, and they can be back to work relatively quickly. So it's much less traumatic for the patient.
So we heard an overview of reflux, acid disease, gallstones, and some of the conditions that result from that. Let me ask a question about a condition that maybe not as common, or maybe not as well understood. Maybe it is common. You mentioned celiac disease when you were talking about different conditions. Is that an area of interest or growing concern in your part?
Absolutely. Like you mentioned, John, the celiac disease, we know there is something like that exists for the last, I would say, at least couple of centuries. But we are recognizing this more and more often. We clearly do not understand why it is increasing in terms of the numbers, what we call prevalence. Especially in the last 4 to 5 decades, it's much more rising in terms of numbers. And the condition is caused by allergy to a protein which is in the diet called gluten. It is specifically, it is in the some kind of cereals, especially the wheat. Unfortunately, most of the bread and other staple food has wheat. Other cereals which may have the same protein are barley and rye. They also can have. This particular protein causes an allergic reaction anytime patient takes it in the small intestine, and that causes different kind of symptoms. We used to have a typical patient, typically in childhood, who is not able to gain weight and who is having a lot of diarrhea and develop nutritional deficiencies, meaning vitamin deficiencies like that. That used to be our typical celiac disease patient. But in the last 2 to 3 decades, at least, we're recognizing very common, and we think that people who have celiac disease, at least known celiac disease, are only tip of the iceberg. Based on some studies in the United States, anywhere between 1 in 100 to 150 patients may have it. And most of the people with celiac disease may not know that they have the disease. The reason for that is a lot of these patients may have only fatigue, little joint pains, what we call arthritis, and dental anomalies, believe it or not, osteoporosis. Young women may have difficulty becoming pregnant. So these many kind of vague symptoms may be there, and an underlying problem may be celiac disease. If there is any good thing about celiac disease is it is very easy to diagnose. There is a simple blood test available, and it's not that expensive, I mean, in the grand scheme of things. And that can diagnose pretty easily. In fact, in Europe, they have a screening program in many countries. They do that routinely. In the United States, we don't do that, but anytime there is any small suspicion, like you mentioned, patients with irritable bowel syndrome, we see as gastroenterologists, and most of the patients with irritable bowel syndrome, especially if they have diarrhea predominant, we tend to do this blood test to ensure that this is not celiac disease, which is presenting as irritable bowel syndrome. A lot of times we do the endoscopy to confirm the underlying problem is the celiac disease, because still we feel that gold standard for the diagnosis is taking a biopsy, which is a small tissue sample from the small intestine. By the way, I would like to describe a little bit about upper endoscopy. I keep using the word endoscopy. Mm-hmm. Endoscopy is a very reasonably simple procedure. What we do during the endoscopy is patient comes to us after 6 to 8 hours of fasting, and there'll be anesthesiologist usually. We give some medication through IV, usually called propofol lately, and patient is completely sleeping. It's not general anesthesia. It's what we call deep sedation, and pass a tiny tube-like instrument through the mouth and look inside. It takes about 5 to 10 minutes. We can assess the seriousness of acid reflux. A lot of times we can diagnose whether people have peptic ulcer or ulcers in the stomach or duodenum. And nowadays many times we take small intestinal biopsies to ensure they don't have celiac disease. I have to say, public also are somewhat more aware lately. It's interesting that it is such a big spectrum, John, in the sense there are people who may not have celiac disease, but they feel that they're sensitive to gluten. And that seems to be another aspect of this also.
Some patients may be more aware of it because when you shop for food now, so many foods say this does not contain gluten, and what you might learn indirectly is gluten is put in a lot of foods that don't have wheat because it's added back to foods that don't have wheat. So whether you're trying to avoid it or you're trying to shop for foods and you see gluten mentioned on the package, I think a lot of people's awareness is growing about celiac because gluten is mentioned all over foods now.
I agree. It is absolutely true. it used to be very difficult for a celiac disease patient before to even go for shopping. But lately, they have a lot of resources, including online resources like Celiac Foundation. They describe very well about which foods are completely gluten-free, what is available in the market. In fact, it's a real big growing market. I have to say though, celiac disease, again, any inflammation in the body, it seems to, in long run, can lead to cancerous condition. The same way, the importance, the reason to diagnose celiac disease earlier than later, apart from making the patient feel better, in long run also we could prevent cancer of the small intestine. Celiac disease is also a predisposing condition. Even though it's not so common, that always adds into the picture. John.
Thank you.
You're welcome.
I'm going to and ask you to talk a little bit about colon cancer. We'd obviously like to find colon cancer at a very early stage, maybe even treat it when it's not a surgery as a treatment. And we've even had whole shows talking about the detection of colon cancer and screening. Can you just give us a little overview of the patients that you have to help when they are found to have colon cancer, and what does it mean when a patient is facing that diagnosis?
Certainly. Unfortunately, most of the patients that I do see have already been diagnosed with colon cancer. It's much better, I guess you've had previous shows about this, to diagnose when someone has a polyp. Dr. Irakam, do a colonoscopy, find a polyp, take the polyp out, and then that's it. But once it converts to colon cancer, it's a much more serious condition. It cannot just simply be removed with an endoscope or with a colonoscopy. It has to be removed surgically. And what that usually entails nowadays is a laparoscopic operation. Depending on where the cancer is, on which part of the colon, you tend to remove a third of the colon. If it's on the right side, then you remove the right third. If it's on the left side, you remove the left third. If it's in the middle, you remove the middle third. These days, I'd say most of cancers of the colon can be treated laparoscopically, like I said before, with the little incisions. It's the same operation, whether it's done open with the traditional larger incision or laparoscopically. It has the same tumor removal rates, the same margin rates, the same lymph node harvesting rates, and certainly the same survival rates. That's been proven that laparoscopic surgery for colon cancer is safe. But it's also been shown to be medically just as effective, but more effective in getting the patients out of the hospital more quickly, having less discomfort, back to work more quickly. So we do try to, if we can, and we almost always can, do the procedures laparoscopically because the patients have much less discomfort and are back to their normal routine much more quickly.
So some of the patients are going to have a polyp and might have treatment and surveillance with a gastroenterologist. Some of the patients might have cancer that's at a stage where they need surgery. Do some of the surgery patients get chemical treatments, chemotherapy, medicines as well?
Yes, after the surgery, after the cancer is removed, all colon cancer patients, would see a medical oncologist, meaning a medical doctor that specializes in cancer. Depending on the size of the tumor and how much the tumor has invaded into the walls of the colon will depend on whether or not the patient's recommended to get chemotherapy to try to prevent the colon cancer from coming back or not. In early stage tumors, most patients do not get chemotherapy, and in later stage tumors, almost all patients get chemotherapy. And that's another reason why it's important, to get a colonoscopy, because it's much better to find tumors when they're cancerous tumors early rather than late. And that's true basically for any type of cancer, but especially true in colon cancer.
Could you just briefly review for us, who are the patients in terms of risk factors or age that you want to recommend colon cancer screening?
Absolutely. Thank you. That seems to be the most important thing. Colon cancer, as you said, is among the top 3 cancer killers in the United States, probably worldwide. And there is a good prevention strategy available for colon cancer. If I have to say one thing, that's the most important thing, is there are different options available how we can prevent colon cancer. At the top of the list is colonoscopy. At the bottom of the list is some stool tests, like looking for a tiny amount of blood in the stool, or lately we also have some stool DNA, which we can check. Again, we separate, John, these into early detection and prevention strategies and early detection strategies. So those stool tests, they are usually early detection strategies, so they're really down on the list. So really preferred method of trying to prevent a colon cancer is colonoscopy. The next best option may be what we call CT colonography, or CAT scan, which is a specialized CAT scan which gives colon pictures. Again, in my opinion, any test is better than no test. And the first thing a patient can do to protect themselves is talking to the doctor about what can I do to prevent colon cancer. What usually we recommend, John, is nationwide standard guidelines are once we are 50 and above years old, we should start doing a colonoscopy. In African American patients, we recommend starting from 45 years. That is for what we say average risk patient, meaning they do not have any family history, they do not have any other predisposing conditions like ulcerative colitis or colitis, other conditions which predispose to cancer, or those genetic conditions where they have a lot of polyps and they develop even cancer at an earlier age. So the general recommendation is starting from 50 years. I can't emphasize more on that. And usually recommended is every 10 years. And also, I would like to add colonoscopy. Every patient comes to me, usually by the time they reach me, a gastroenterologist, they're kind of convinced to have a colonoscopy, but I'm sure the primary care doctors such as you have difficulty convincing the patients. I'd like to say colonoscopy is a reasonably simple procedure. Most of the people say their problem of having a colonoscopy is the day before the preparation, but once the preparation is over, they really don't feel anything. Again, anesthesiologist will be there. They're painless during the procedure. They may feel a little gas for an hour or two after the procedure. It's reasonably very safe procedure. There are obviously some complications, but again, when we look at the benefit and risk, benefits are way higher than the risks.
I want to thank you, gentlemen. We covered colon cancer screening, celiac disease, acid reflux disease, gallstones. We had the surgical viewpoint and the gastroenterology viewpoint. I want to thank you both for providing this information for our patients today.
Thank you so much
John.
for having us, John.
This concludes today's episode of Somerset Medical Center's Health Talk. Please remember that the opinions expressed here by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referral number at 1-800-443-4605. For more information about Somerset Medical Center, visit somersetmedicalcenter.com. Thank you.